Great. Good afternoon, everyone. My name is Barbara Kowalcyk, and I'm happy to welcome you to this virtual briefing on Cyclospora from Oocyst to Outbreak. Just a few record-keeping things before we jump into it. This event will be recorded and available on our website and hopefully on YouTube later today. We are asking people hold questions until the end, and when we call on you, please state your name and affiliation. Here's an agenda for today's event briefing, and you can see we have four separate talks. And I will briefly introduce myself. I'm Barbara Kowalczyk, and I am faculty here at George Washington University, where I direct the Institute for Food Safety and Nutrition Security. I am an epidemiologist and biostatistician by training, and have been working in food safety for about a little over 20 years. Our other three panelists are Don Schaffner, who is a distinguished professor at Rutgers University. He's a microbiologist and a food safety specialist, so lots of expertise on the production side and microbiology side. We also have Dr. Craig Hedberg from the University of Minnesota. Craig is an epidemiologist and was previously with the Minnesota State Health Department, so can give some unique perspectives from that. And then we have Sarah Sorscher, who is an attorney and has a strong background in law and public policy, and she is the Director of Regulatory Affairs at the Center for Science in the Public Interest. So hopefully you'll all get some really great perspectives from bringing all of these different people together. So I'm going to go ahead and just kind of kick us off with a few brief slides on kind of the Cyclospora outbreak in context. I think that it's important to note this is a quickly evolving outbreak, and it is unclear at this moment if it is a single outbreak or if we have multiple state outbreaks or multiple outbreaks going on at one time. Right now, their reporting has us over 7,000 illnesses in 34 states. You can see a lot are centralized on the East Coast and the Midwest, but that doesn't necessarily mean you also have some light blue states out west. But, this outbreak is quickly evolving. And of course, this is a parasite. Person-to-person contact is pretty rare. But what we want to talk to, Don will get kind of into that information. But I want to talk about, this outbreak is also a symptom of potential system vulnerabilities. So surveillance really drives prevention, and our ability to detect, investigate, and respond to foodborne disease outbreaks helps us understand the scope of the problem. That leads to investigations and root cause analyses that help us prevent what happens the next time. So it's really important we understand right now, is this one outbreak? Is it multiple outbreaks? How did these outbreaks happen? Because that's the only way we're going to prevent them going forward. Also, sometimes we identify new hazards, right? Or new transmission pathways. I know there's a lot of speculation about what is the potential source of this. It's also possible that it's a source we haven't identified yet. In which case that can lead to applied research, additional prevention measures, and our surveillance also gives us feedback on how those prevention measures are working. Now, we like to think of our surveillance system as a system. It's actually different pieces of a puzzle put together. So here on this slide, you can see that we have lots of different systems that actually inform or provide surveillance around foodborne pathogens. The two green ones are more funding mechanisms, so I wanted to call those out. The ones people typically think of are FoodNet and PulseNet, and Craig will get a little bit more into the differences of those, but these systems all provide different perspectives, okay? And they work together and provide an overall picture. And one of the concerns that I think it's important for us to realize is that you start pulling pieces of this puzzle apart, it makes it really hard to see a complete picture. Now, CDC, most of these programs are funded by CDC through block grants to the states. This is CDC's Beam dashboard. You can see for food safety, CDC is funding about 283 programs across the states. And again, this happens at the state and local level. And these investments have really, really paid off. So we have seen just from PulseNet, which is only one of those systems, that investing $1 in PulseNet, for every dollar invested, we saved $70 in terms of preventing medical costs and lost productivity. Investments in PulseNet also led us to reduce the amount of time it takes to detect an outbreak and detect outbreaks when they're smaller. It's led us to identifying additional foods that we weren't aware of before that have been associated with foodborne disease. And investing in updating PulseNet's laboratory methods to whole genome sequencing, that was a $22 million investment. You can see here that has led to $570 million in savings each year in terms of medical costs and lost productivity. Unfortunately, CDC's food safety funding this is adjusted to 2026 dollars. You can see it really hasn't had a huge investment since 2014, 2015. It's been fairly flat, and with inflation, that means it's going down. I think it's important for everyone to know that CDC's food safety budget is about for food safety is about $74 million a year, and half of that goes to states. And CDC is really not meeting the state's needs. So what is the current situation? Before I hand it over to Don, really, we know that foodborne disease is a serious public health issue. We have 48 million Americans sickened each year, resulting in 128,000 hospitalizations and 3,000 deaths. This results in an estimated $75 billion in annual costs. And that doesn't even include the cost to industry or the cost to the public health agencies. We also know from our data, here you can see the 2023 food safety report card that CDC put out from FoodNet. We haven't gotten a more recent one, but you can see we're not making the progress that we really have wanted to and the goals we've set for ourselves in terms of foodborne disease. And you can see Cyclospora is greatly increasing. And unfortunately, CDC has been facing a huge budget cut across the board. And if you go back to that puzzle, right, a lot of those different funding mechanisms support foodborne disease surveillance, which is really, really critical for prevention. I'm going to stop there and I'm going to hand it over to my colleague, Don Schaffner.
Thanks, Barb. So what I'm going to try to do for us on the call today here is to talk a little bit about the microbiology of Cyclospora and give you some idea about what we know and what we don't know. Next slide, please. So here are some things that we know. This organism is different than some of our typical bacterial pathogens like Salmonella and E. coli. The incubation period is relatively long. Could be as short as 2 days, but it might be as long as 2 weeks. And that has implications in terms of the epidemiology because people's memories start to fade. Unlike Salmonella and E. coli, chlorine is not very good at inactivating the oocysts of this organism. Washing is not effective. Every time I read a news story and it talks about the oocysts clinging on to fresh produce, it makes me roll my eyes a little bit. Washing is not a terribly effective intervention for any pathogens that are associated with fresh produce. Telling people to wash their produce, it maybe feel good, but it does not really doing anything to actually manage risk for people. Again, I cringe a little bit every time I see someone recommending hand washing. Hand washing is great, but it has nothing to do with managing this particular microorganism. What does work is cooking, but of course, you're probably not going to cook your salad. But cooking is effective at inactivating this microorganism. Interestingly, this disease appears to be from humans and spread to humans. There are no other hosts. There are no other animal hosts involved as far as we know. Interestingly, although explosive diarrhea, recurring bouts of explosive diarrhea sounds horrible, this disease is almost never fatal. So people really don't die from this, but they can be miserable for a long time. The disease is relatively treatable as long as you're not allergic to sulfa drugs. It's not spread person to person. See my comments about hand washing, because when someone who is sick with this disease has this watery or explosive diarrhea, that contains oocysts, but those oocysts are not immediately infectious. And so they need some time in the environment before they become infectious. So it's not spread person to person as far as we know. In preparing for this call, I was talking to some friends and colleagues, and one of them made the comment that if we had more oocysts available for research, more scientists could do research. So scientists need your poop here. Um, this organism is a parasite, which means unlike Salmonella and E. coli, you can't cultivate it on laboratory media. The only way to cultivate it is in a human host, at least as far as we know for right now. And Barb alluded to this a little bit before. This is in gray because it's not what we know. It's my own personal opinion. I do think cuts at the federal level will weaken our future ability to manage risk from this organism. And I think Barb put that very eloquently in a few more words than I did. Now let's move on to what we don't know. Next slide, please. We know that infections peak May to August. We don't know why. There obviously is a clear seasonality here, but the reasons for that seasonality are unclear. We don't know the prevalence of the organism in different water sources. It's a difficult organism to detect. It may be present at low levels or only sporadically, so that complicates things. We we don't know what the prevalence is, and we also don't know what factors drive that prevalence. What are the things that cause the organism to show up in the water supply? We don't really have cost-effective mitigation measures for water treatment right now. I mentioned before, I think I mentioned before that the organism is relatively resistant to chlorine. So unlike chlorine, which will readily inactivate Salmonella and E. coli, or can readily inactivate them, that's not true for this organism. So we need something other than chlorine to try to inactivate this organism. It is handled during sewage treatment, but in the settling phase, not in the chlorine treatment phase. Barb alluded to this a little bit already, some of the great advances we've seen from whole genome sequencing. We don't have rapid methods. We don't have next generation or whole genome sequencing for this organism right now. CDC does have some typing technologies, molecularly based typing technologies, but they're not as precise or as good as whole genome sequencing. We don't know, believe it or not, what the predominant mechanisms are that result in produce contamination. Is it flooding of fields? Is it irrigation water? Is it pesticide makeup water? Is it post-harvest washing? Is it something else? We just simply don't know. We also don't know why it takes oocysts that 2 weeks to become infectious and what factors drive that process. And then finally, for people like me who want to do risk assessment and risk modeling, one of the things that we need to do that is a dose response relationship. So what the dose response relationship will tell you is if I ingest one oocyst, I have some probability of illness. If I ingest 100 or 1,000 or 100,000, we suspect that the probability of illness goes up, but we have no idea what those numbers are. That's unlike, again, pathogens like Salmonella and E. coli, where we have at least some idea of what that dose response relationship is. So there's certainly a lot of work still to be done in terms of the science and understanding what's going on. And that's it for me.
Thanks, Don. Up next is Craig Hedberg from the University of Minnesota. Go ahead, Craig.
Great, thank you very much. I want to talk today about how we conduct surveillance for foodborne illnesses in the United States. And I call back this map that Barb showed earlier with the distribution of cases across 34 states. In the United States, our reportable disease systems are based on individual state reporting requirements. We have Cyclospora is a nationally reportable disease, and what that means is that the states and CDC have agreed that it's an important disease we want to be able to track, but reporting is an individual state requirement. And so every state rule operates a little bit differently. In some states, Actually, it's the county or the local health department that has primary responsibility for collecting data and investigating things. In some states, it's at the state level, and in some states, it's a combination of cooperation between the state and local agencies. So when we see a big multi-state outbreak investigation like this, as cases are reported to individual local and state health departments, investigating the outbreak requires a high degree of collaboration and coordination across many different state and local health departments. And one of the things that becomes challenging with Cyclospora in particular is the long incubation period, as noted previously. And in a lot of outbreaks, we're asking about food items eaten over a relatively short time frame. With Cyclospora, we're trying to collect information about food items eaten over a period of 2 weeks. So in each of the states and local health departments, they'll be interviewing cases that are reported to them, trying to ascertain food items eaten over the past 2 weeks, looking for restaurants, grocery store sources, looking for clusters of cases that might be linked to specific establishments or groups of establishments that could be an indicator that whatever the contaminated food item is, it was moving through that food distribution chain. And that's the information then that the FDA and the state departments of agriculture need to begin to trace things back to identify, where there might be common sources that could explain some of the distribution of cases as we see them. And what we can also see when you look at this particular map is that, we may well have multiple different things going on simultaneously. And that complicates our search for a common source as well, because if the cases in Ohio and Michigan are different from the source of the cases in Texas, then trying to find a common source between the two is really not going to lead to anything productive at all. So that is what people are working through right now. If you could go to the next slide again, Barb. Yeah, so as she also noted, surveillance is really our key to identifying, what's going on here. Once we recognize that there's an outbreak going on at a local level or at the state level or a multi-state outbreak investigation going on, we have epidemiological, laboratory, and environmental investigations occurring sort of simultaneously. So as I indicated, individual cases are being interviewed to try to identify what food items were eaten in the period of 2 weeks before the onset of illness. We're looking for common potential sources, distribution pathways that then might be traced back to identify whether or not there's a common source that could explain, that distribution of cases. The incubation period is one that is long. Also with Cyclospora, because people have sort of intermittent or prolonged symptoms, people don't necessarily go in to seek medical care as early as they do with some of our other foodborne organisms. So we're getting a lot of information that we have to understand and put together in a complex way. So when we see things like leafy greens emerging as a common likely source, we need some perspective on that as well. Leafy greens are one of the most common food items that we typically consume during the summer months and really all year round. So it's not enough to know that people are eating lettuce or leafy greens. What really matters is, what type of product is that and what is a potential common source of that. And that is important information actually to guide all of the recommendations that come forward in terms of how can we help people prevent illnesses from occurring? And I will stop there and turn it over to Sarah.
Hi, Sarah, I'll turn it over to you.
All right. Well, I am Sarah Sorscher. I'm the Director of Regulatory Affairs at Center for Science and the Public Interest. And we are a consumer advocacy nonprofit. We're based in Washington, D.C., and for more than 50 years, we've been fighting for stronger food safety protections. And I'm here today to make the connection between the current outbreak and the policies that may have contributed to the current problems that we're seeing, as well as what members of Congress can do right now to address those issues by providing funding for food safety surveillance. And really, one of the problems that we have right now is that we know there's a large outbreak. We know it's centered in the Midwest, and we don't have great clarity about what caused it or what we as consumers can do to protect ourselves. We heard from John, we can't wash the vegetables, but other than that, we don't have information about actually the steps we can take to stay safe. And there have been a lot of elements of the outbreak investigation that have also added to this sense of threat and the confusion in the outbreak. We've seen delays in reporting between the states and CDC. The outbreak was posted first by Michigan's health department at the start of July, and CDC didn't actually get its own outbreak investigation notice up until this past Tuesday. Other states are reporting their own numbers. This sort of 2-week delay has caused a lot of confusion because reporters are looking for data. They're visiting CDC's website and they're seeing the Cyclospora surveillance landing page, which gives just nationwide numbers for all cases in the country this year, some of which are not part of that Michigan outbreak. They have independent causes, and they're sort of, some of them aren't elevated above expected, some of them are travelers' cases, and so that's very confusing. This has sort of led to the appearance that we have one outbreak that's spread to more than 30 states when really it's centered in Michigan and the nearby states, Ohio, West Virginia, and Kentucky. And there's also been a lag in the reporting of case counts by CDC, with state websites reporting much higher numbers than the federal website, which makes it hard to know the number of people that have been affected. But the biggest issue is that neither CDC or its state partners have identified the food or water source that caused this large outbreak. And there is no way then for consumers to eliminate that pathogen on the fresh produce that we have other than by cooking it. And that's giving people a lot of anxiety. So particularly for parents with young kids, the elderly, people who know that they are in a high-risk group for foodborne illness, they're concerned about now fresh produce in general, and they don't know how to protect themselves. And so it's a perfect storm for viral news. A lot of people have been posting on social media about avoiding fruits and vegetables, which is not good public health messaging when we know that a vast majority of these foods are certainly not part of this outbreak. And we know that Americans actually need to be eating more fresh and minimally processed fruits and vegetables in general for our health. But I think it's also really important to be crystal clear that this confusion that we're seeing is not due to any lack of skill or dedication by the CDC staff, right? These are scientists who have trained for decades to do this work. They have stayed at their posts working overtime through a pandemic, working unpaid through multiple government shutdowns, not to mention the mass shooting at CDC headquarters, losing colleagues to chaotic firings and reorganization. And they're still at their posts, and you would actually be hard pressed to identify a team of people who is smarter, who is more skilled and experienced and more committed to their work than the men and women who are working right now on solving this outbreak. But the issue is that these programs are completely overwhelmed by the scale and scope of the work of solving and communicating these novel emerging outbreaks with a dwindling set of resources. And we have to remember that federal investigators really do need to double and triple check every communication that they make, because any missteps in an outbreak will cost them credibility that they cannot afford to lose with the American public. And that type of accuracy takes resources. And if they don't have the resources, it's going to take a lot more time. And so that's why we don't have the answers yet that we need in this outbreak. And we know that state and federal programs are being drained from multiple directions, as Barb highlighted the numbers on her slide, but I think there's really sort of three buckets that we need to think about here. First is a loss of expertise. So at CDC, experts have left due to mass layoffs and early retirements. The agency was projected to lose 20,000 people last year. That's a quarter of its staff overall. Cuts to global health in particular have led to a brain drain in experts who study tropical diseases, and Cyclospora is a tropical disease. And then secondly, there's this strain on the state and local partners. So as of May 13th this year, the Trump administration has terminated 5.8 billion in grants that Congress had already allocated to the states and to researchers under its constitutional authority to direct taxpayer dollars. And just to put that in perspective, that represents about 45% of the overall 12.5 billion in grants for public health that were allocated in fiscal year 2023. And so state and local governments that were expecting that funding are now looking to triage programs across the board, and they're making cuts to food safety. And that's why we saw CDC making cuts to FoodNet last year. They stopped asking the states to monitor these long-term surveillance of cyclospora and other pathogens, these trends, because the states are running out of money and they're stretched thin just solving the outbreaks. So FoodNet cuts didn't cause this outbreak, but they are a symptom of a deeper problem, and that is that our outbreak response programs are running out of money. And that's all just colliding with the fact that CDC's food safety budget is stagnating relative to inflation. Barb had that great bar chart showing how it's going down in real dollars. And they don't have the resources to meet the demand that's now coming from state and local partners. And that's why we're seeing CDC only able to meet 40% of the requests for that have come from state and local partners in the past year. And I think the good news is that there is strong bipartisan support for food safety. And we are actually now in a moment right now when Congress has the opportunity to remedy some of this shortfall because they're currently considering next year's appropriations bill. And what right now, the House FY27 Labor Age Appropriations Bill that was approved by committee in June does include a small increase for CDC food safety, but it is small. It's about $5 million or a 7% increase in the existing CDC food safety budget of 74 million. But we know that the need is much higher than that. So that's why last fall, my group, CS Center for Science and the Public Interest, and our coalition partners joined in a multi-sector letter to Congress calling for increased funding. That letter was signed by 27 groups that included trade groups representing food businesses that are impacted by these unsolved outbreaks. We know there's broad support for CDC funding because unsolved outbreaks are bad for business as well as for people. And that letter requests an increase in CDC's food safety budget by 50% or 37 million on that existing budget of 74 million. We have to remember that foodborne illness writ large is estimated to cost the US economy more than $74 billion annually in medical costs and lost productivity. And it's also estimated that for every dollar that we spend on PulseNet, CDC's foodborne illness detection system, Americans get a $70 return in cost savings from that prevented illness. So, and that's really because swift outbreak investigations get us faster recalls, they get us faster understanding of the root cause, and ultimately better prevention of outbreaks. So I think the bottom line is that Americans really deserve to know whether the produce that we have at home in our kitchens is safe or not, right? And we are not going to get a straight answer on that until Congress and the president start giving this issue of foodborne illness surveillance the attention that it warrants with funding. So I think we had a lot of questions in the chat, so I'm going to kick it back to Barb to take us to the next section.
Okay, so we're going to open up. I'm just going to show this for a minute and ask the panelists to come off video or come on video. Great. And I will start to look at the Q&A and see what we have here. And certainly you can raise your hand and we can pull you off mute. So the first one is, thank you, Thomas, from Consumer Federation. He's already posted the letter that the coalition had issued in terms of full funding for FoodNet and the CDC food safety program. So there is a question, and maybe Craig or Don can answer this. I don't know. Do we know if any local water sources have been tested?
Not aware of any.
No.
No. And of course, this is something that we really do need to have better understanding. And again, this is getting to the root cause. Is there more specific guidance you can provide on cooking, such as duration, temperature, etc.? Don, can you take that one?
Yeah, so the I put in the answer in the chat that 160 Fahrenheit should be good. I'm just actually looking up a reference. There's not a lot out there, but there is a paper in JFP from Inez Ortega, and I'm just in the process of doing the conversion of degrees C to degrees F. I'll put it in the response in just a second.
Okay, great. Why do you believe this outbreak is so much larger than prior Cyclospora outbreaks? Craig, do you want to take a shot?
Well, sure, I can take a shot at that partly. I think there's a couple contributions. One is that right now, most of the cases of Cyclospora that are being diagnosed through what we call culture-independent diagnostic testing. These are PCR-based panels that can screen for like 20 different pathogens all at the same time. These panels are much more widely used today than they were, say, 10 years ago. So we have much better ability to pick up these infections at the clinical level than we used to have. The other thing that happens in the context of an outbreak like this, once word of the outbreak starts to spread around, people go in for testing who might not otherwise have been tested. So aside from considerations of the food item that might be in distribution and the contributions of that, the clinical diagnostic world has changed in important ways that makes it more likely that these cases will come to detection.
Okay, great. Anybody else have anything to add?
I want to back up to one beat and mention the letter that Thomas posted in the chat is actually to a draft. So if you're on the call and you're from a nonprofit and you'd like to sign that letter, please do. We're going to be re-upping that to the Senate. But if you're a reporter and you're interested in reporting on our letter from last fall, I've added the link to that question answer, and you can report on that today.
Okay, so we also have a question from Sarah from USA Today. I think that kind of goes to the same question that Jerry had in terms of why cases are so high this year. Is it due to scaled back surveillance, better testing diagnosis, a combination of factors? Is the infection worse this year? And I think what you heard from Craig and certainly my opinion is it is a combination of factors. And another thing that we might have better testing and diagnosis. We've also a lot of these pathogens like hot, humid weather, and we certainly have changing weather patterns, and it may be a new vehicle that we haven't identified before. I think the big concern that I have is, ideally we would identify these outbreaks before they got to 6,000 or 7,000 cases. We would identify them when they're small. We'd be able to intervene and prevent them from becoming so big. And so that's my concern, is that the fact that there's been across the board funding cuts for public health is that we're really hampering and strapping the people that are charged with doing this. Anyone else on the panel want to add?
Yeah, no, I just, because our surveillance system is based on what happens really at a state and local level, it's those resources that really have to be distributed very widely, which is what, we need to be able to respond to outbreaks, because we never really know where these outbreaks are going to be happening.
Great. And then Susan Main asked a similar question, expect increases in infections. And I know there's a lot of confusion. I've gotten a lot of calls, I think all of us have, about FoodNet, and it scaled from 8 pathogens to 2. It actually didn't have a funding cut. I think it's important to say that. Really, the system was never funded adequately to track 8 pathogens. It was, and they had to right size expectations for the amount of funding that they have. But FoodNet is not designed to detect outbreaks. It is designed to monitor trends. So it's really important for us to have that. And Cyclospora was dropped last year, so we're not going to have the context for us to look at how this outbreak fits within the broader trends. Really, our National Notifiable Disease Surveillance System and PulseNet are more designed to detect outbreaks. So yeah, it's all going. I'm trying to keep up with the chat. Lots of great questions. Lynn Goldman asks, so Cyclospora only infects humans and only is transmitted via human fecal waste and the fecal oral result, and certainly keeping human feces out of any source waters that are used for irrigation. Don, would you like to go ahead and answer that?
No, I actually have my hand up for a different reason. Sorry.
Oh, okay. Go ahead. Go ahead.
So I want to apologize to Brian Souders, who put a question in the Q&A, and then I was responding to a question underneath that, and so his question got removed, and I just want to call it out here. It's probably a question for Craig. Food histories are often subject to gaps in memory. Shoppers' cards and credit card receipts sometimes are helpful, but there are folks out there logging food consumption with photos for health or diet nutritional counseling purposes. Have epidemiologists used these apps to aid in acquiring more detailed food histories? Has AI been used to interrogate food history data? If so, is AI helpful?
And I'll give you I don't know the answer to that question. I do know that, there are a lot of tools which are used to try to increase the recovery of information and shopper cards, reconstructing credit card purchases, looking at online purchasing records. All of those things are routinely done in the context of outbreak investigations.
Yeah, and I think, and this is something Craig and I have talked about, I know I've heard Craig talk about it many times, is, one of the challenges we have is really trying to help people remember what they ate 2 weeks ago, right? I can barely remember what I ate last week. And, that takes a lot of research. It takes a lot of understanding, engagement of social and behavioral scientists. And we haven't really been investing in research to improve the exposure assessment tools we have for foodborne disease surveillance. So again, I hope your takeaway is that this is a large puzzle, right? And we need additional research funding to be able to address the we don't knows that Don highlighted. We need additional research funding and to better understand how we can solicit exposures from people and so forth. So we need funding across the board. I'm going to try and go back to the chat, and we can go over the 12:45 time a little bit, but just one question, is some of this potentially coming from farms in terms of poor sanitation? Don?
Well, it's an interesting question, right? Remember that it's not spread person to person. So if a farm worker has cyclospora, they probably don't have, and they have diarrhea, they probably don't have infectious oocyst on their hands. So I think certainly worker sanitation is important and everybody should wash their hands, but I don't think, my guess is, and it's really just a guess, but I think others might agree, that it really, to me, it fundamentally comes down to water, not worker sanitation. Now, obviously, if you have a latrine and that drains into water that you're then going to use to apply to the crops, well, that's a bad idea. But we already know that's a bad idea, and farms are already managing that risk.
And I'll just add to that, in case the question was intended to get at farm animals and concentrated animal feeding operations, that's a big issue in other outbreaks. For example, with pathogenic E. coli, a lot of times it's grown in the guts of cattle, right? But that's not true for this one because it only has human hosts. So that can't be the explanation here.
Next question, can you speak to the difficulty of determining whether a patient has cyclospora? This comes from Kate Ryan. She's hearing that the type of stool tests to confirm are not common, so this seems to require persistence from both the patient and the doctor.
Yeah, I think there's really two ways that that the diagnosis can be made. One is I talked about these CIDTs, the PCR-based syndromic panels. Some of those that are in routine use around the country do include Cyclospora, some don't. So if somebody's going in to get a diagnostic test and that test kit that's being used doesn't include Cyclospora, then obviously that's not going to diagnose it. The other thing is through just a microscopic examination of stool to look for the presence of the oocyst. And prior to the development of the PCR-based panels, that was really the main way that these cases were being diagnosed. But I think that right now, most cases are being diagnosed through the use of the CIDTs, and the which panel is used at the laboratory that's doing the test could be a limiting factor.
Right, and I think it's important to, I know there's been a lot of guidance to healthcare practitioners. Sometimes they don't want to order a stool sample, or the patient doesn't want to provide one. It's not always a pleasant experience. And I know I've seen several announcements going out trying to really encourage physicians and healthcare practitioners to order those stool tests. Again, that's how we're going to, the only way you get into the surveillance system to be counted is if you are a confirmed case. So just to answer your questions. We have another question from Kate Wells of KFF Health News. Are there concerns that other potentially more deadly outbreaks that have also had surveillance cuts, such as Listeria, could now become worse? Anyone want to take that?
I'll just
Yes.
say, again, I'll just say that the way we do surveillance for Listeria is actually a little bit different from the way we do surveillance for diarrheal diseases, because Listeria typically presents as a severe infection that results in hospitalization, and it's usually through blood cultures that those cases are being diagnosed rather than stool exams. So the cuts to our surveillance systems at a state and local level are going to limit our ability to follow up with Listeria cases in a similar way. But those are followed up on in a very different manner than most diarrheal illnesses.
All right, next question, since we've got a lot in the queue. Could produce be imported from other countries, and are we checking for international sources? That comes from Lynn Allison from Newsmax. Don, do you want to take that?
Yeah, well, I mean, certainly the answer is yes. That's possible. At this point, we just simply don't know. The FDA's tracebacks are still ongoing, so we just simply don't know. What we can say is that yes, it has come from. We have people that are sick with traveler's diarrhea from traveling to other countries. We have people that are potentially sick from eating imported produce from past outbreaks. It first came on our radar in the U.S. with Guatemalan raspberries in the mid-1990s, so that's certainly possible. But at this point, about these specific outbreaks, we just simply don't know at this time.
Okay, great. We have also a question from Nate with the Hill. Is there anything CDC and FDA should have done differently that would have caught the outbreak and potential source sooner than there were so many cases? Anyone want to take it?
I think at this point it's really not clear, what could have been done differently or should have been done differently, other than sort of looking at the details of the investigation as it happened. As I mentioned, at a local level, you're looking for clusters of cases that might have a common exposure. So if you identify that there's a group of restaurants, say that may have been part of the outbreak, then the challenge is, figuring out what was the ingredient that was moving through those restaurants that was the cause of the illness. And in a lot of food items, what you actually order is a combination of different ingredients. And there are ways we can use epidemiologic investigations, looking at case control studies, looking at ill people compared to healthy people who had a similar exposure, that we can tease that apart. It's not clear to what extent, those types of detailed source investigations have been conducted as part of this outbreak investigation, but that's where I would put my emphasis.
Yeah, and our epidemiologist is focusing on the epi work naturally. And there's also there's a sort of three prongs to outbreak investigation. There's the epidemiological work, so surveying people, figuring out what they ate, looking for common threads. There's the laboratory work that happens, so testing those stool samples and doing genome sequencing where feasible. And then there's the traceback work that either FDA or USDA is doing, like tracing food back to common sources to see what might have caused the outbreak so they can do the appropriate recall. And here, if we'd had more investment in the epidemiological work, so having more epidemiologists at the state level through funding state programs adequately, or if we'd had better laboratory work, so more funding for state labs, then that could have provided data to potentially catch this earlier. But the way it was caught was just Michigan sort of noticing a huge surge in numbers. And when you sort of leave it up to that, then you end up with massive outbreaks. And so to Barb's point, investing in PulseNet, investing in these other systems has been able to make outbreaks smaller over time. We just haven't seen that happen here with Cyclo.
Yeah, and I think one of the important things that we should be asking for is an outbreak after action report from the agencies. Sometimes they do those and publish them where we can actually look at and they do a hot wash afterwards, right, to see where were their breakdowns, what worked well, what didn't work well, and I think we should be asking for that. Erica Edwards asked, does tracing these outbreaks simply rely on interviewing patients and genetic sequencing? Could someone please explain in lay terms the sequencing that's done for this? Do most public health departments have that capability? I'm not a laboratorian, so I'm going to shoot it over to Craig and Don. But from my sources, I'm hearing that no, for Cyclospora specifically, most public health departments do not have that laboratory capacity. Craig, could you take the first part of the question, and Don, can you take the second?
I don't remember what the first part of the question was, but I will.
Relying on interviewing patients and genetic sequencing.
Yeah. Well, again, as Don pointed out, one of the things we don't really have is the ability to do the genetic sequencing in real time across the system that we do with, say, whole genome sequencing of Salmonella or Shigatoxin producing E. coli. So that really does leave us a lot with interviewing the patients, but there's a lot more we could do with interviewing the patients than just tabulating how many people ate this different food item. And I'll leave it over to Don for the follow-up on that.
And I'll also beg forgiveness and ask, what was the second part?
The second part was, could someone please explain in lay terms the sequencing that's done for this? How do you test for this?
Oh, geez. We need somebody who's a more molecular microbiologist than me. So I rather than give a wrong answer, I think I'll pass.
Okay, fair enough.
And also, I will say there's plenty of smart people on the call. Callie Neal from University of Delaware is on the line. Reach out to her. I'm sure she'd be happy to talk to a reporter with those kinds of questions.
I'm happy to, not to put Callie on the spot, if she wants to answer in the chat or come off mute, I can certainly manage that. Okay. I just noticed there are some people with their hands raised. I'm going to switch over to that. Christine Howard. Go ahead. All right.
Christine, you'll have to unmute if you want to ask a question.
All right, I'll move on to the next one. Oh, go ahead, Christine.
Uh,
Thanks, second,
Michael?
Michael.
it's Mike Stobie. Can I ask, or is
Yeah,
Christina?
go ahead.
Okay, sorry. Two quick questions. Thanks for doing this call. First, I was wondering if you could say a little bit more about, you've answered this to some extent, but what should the CDC be doing, and are they doing it? You've talked about budget cuts, and the agency's lost a quarter of its staff in the last year, but the parasite team is still the same size. Is that right? Do you have any understanding of how operations have changed or not changed in the last year? That was my first question. And my second question was, you've noted how the circumstances have changed and testing is different, but can you compare this outbreak to past Cyclospora outbreaks, which have been linked to a particular produce item? Did it take 2 months to detect the source? Is this common? Does it usually take longer? Does it usually take shorter? Thank you.
Barb, I don't know if you want to say anything about CDC's organization or operations. I will say that, in previous outbreaks associated with Cyclospora, it does require some effort and time to work through the cases and get to the source. And so to that extent, this isn't all that different. But I think, what we have to do is to try to learn from previous events to improve our processes, to get to answers quicker.
Yeah, and I'm struggling a little bit to manage all the questions and keeping on top of it. But I think one of the other things that it's important for people to keep in mind is that for CDC, there's kind of the traditional food and waterborne group, and then there's the parasitic group. So when these cases go to CDC, they're going to the parasitic division, which right now, even though it's not a human health issue, they're dealing with things like New World screwworm, and I think they have 80 parasitic diseases that they are dealing with. So again, it comes back to that capacity issue. I'm going to go next, Michael Hansen.
Yes, can people hear me?
Yes, go ahead.
Yeah, my basic point, I think, is to Dr. Hedberg. If you look at the numbers, they go up from 537 in 2016, and every year they go up except for the 2 years of the pandemic, and then they're up to 4,463 in 2023. We don't have data for 24 or 25, but you see this consistent increase. Mm-hmm. And is that just due to the use of the PCR test? Like, when did they come in? Because it's interesting, year to year, it's always increasing.
Right.
And so, or is something else going on?
Well, I think it's probably a combination of things, but the use of the CIDT tests has to be a big part of that. Those tests they start to become used, in the mid-teens, like 2014, 2015, and become more widespread. So that over this, if you look at the CDC FoodNet data for Cyclospora, there is a marked increase in that is largely due increase in reporting, which is largely due to the use of CIDTs at clinical laboratories. There may well be differences that are going on with the distribution of this parasite in nature and its availability to contaminate food items. Those are questions that we just don't have answers for right now.
Okay, great. Kate, I was going to go. You have permission to talk. I was going to actually highlight one of your questions, but go ahead.
Oh, okay. Well, if there's something you want to highlight, please do.
Go
but
ahead.
I will say, and Professor Schaffner got to this a little bit here, on the frustration that consumers have, because they're hearing from us reporters who are hearing from health officials in our states, hand washing is good and can help reduce risk. They're not saying it's going to keep you from getting this, but they're saying it reduces risks. So people are very frustrated and they're like, shoot, should I just eat Milky Ways forever and skip the greens? What do I do about my diet? What's trustworthy right now? And how much damage do you think to the confidence in our food system is this particular episode having right now? And thank you very much for doing this. This is incredibly helpful.
Thanks, Kate. So what I'll say is I have not changed my consumption patterns one bit. I would say remember that most produce, most fresh produce is not contaminated with Cyclospora overwhelmingly, 99.9%. Obviously, if you think that you want to be take more precautions, then that's great, do that. I just don't want people to think that hand washing is great, right? We've studied hand washing in my laboratory. It's wonderful. It's not a great intervention, and it's a totally useless intervention when it comes to this particular problem. Same with washing. I mean, yes, you can wash produce and you can remove microorganisms, but again, not going to be helpful in this case because the doses may be high enough. Even after you wash, you still have enough oocysts there to be infectious. But see my earlier comment, we don't have a dose response curve. Yeah, so. I feel for people that are concerned, but but I'm not gonna stand by and let people say stuff because they want people to feel good when that has no benefit when it comes to risk.
Yeah, and I think, go ahead.
No, I was just gonna just say again, we encourage people to eat fresh produce. It's an important part of your healthy diet, and and I think there is a concern that, the very broad recommendations that are being made, could cause people to avoid eating produce and substitute that with other things, that are also problematic.
And I will say, as a mom with young kids who don't like cooked vegetables, they eat a lot of romaine, they eat a lot of berries. And when I see headlines about outbreaks, I stay the course for their diet. Because I know that by the time an outbreak gets reported, oftentimes that food is out of the system, and the food that's on my plate and in my kitchen is the same risk that it always was. And when I look at the benefits of fresh produce and I look at the risks of foodborne illness, I know that the benefits it's more important to me that they get their fruits and veggies. And so, unless there's a recall that can identify a specific item, then I will act on that, but I will not change my diet based on headlines.
Yeah, and just I want to just comment that, risk, everybody has a unique risk tolerance, right? And that's something that they have to make a decision on whether or not they feel comfortable taking the risk. I always say all food comes from the ground or animals. It's not sterile, right? And so there's always going to be a risk there, and you need to make an informed decision about that risk, which kind of depends on what your own personal health status is. If you have a compromised immune system, then maybe you would make a different decision. I think the point that we can, it's good to think back to, I almost hate to bring up the COVID Swiss cheese model, but it really applies here in food safety. We talk about a multi-hurdle approach. So, if you're concerned, there's lots of steps that you can do along the way to reduce risk. You won't eliminate it, okay? And you can reduce it. So if you're really worried, grill your vegetables. I love grilled vegetables, right? I personally am not stopped eating fresh produce. I've reduced my consumption in some cases, but I have a very low risk tolerance in this area because of my own personal experience. And so I think it's really hard for experts like us to give those blanket statements. I personally am not in the business of telling people what to eat or what not to eat.
Agreed.
John, I think I'm probably going to let you have, John Besser, I think I'm going to let you have the last question before we wrap.
Thanks, Barbara. Can you hear me?
Yes.
Yep. Great. 2 comments and a question. One, there's been some organizational changes at CDC, and Cyclospora is now a joint responsibility between the Foodborne, Waterborne, Environmental Group and the Division of Parasitic Diseases, which is great because they have daily experience with handling these outbreak investigations. And the second was add to the question about molecular subtyping. That is a huge problem because, as Craig pointed out, you can't separate the sporadic cases from the outbreak cases or separate things going on, which makes it really hard to find a common source. But it is more difficult for Cyclospora because it's diploid, it's a very huge genome, and they use something called amplicon sequencing to subtype it, and it is used experimentally at CDC, but is not in most of the states or any states, and also interpretation is really difficult. The last is a question primarily for Craig. We've seen big issues with cryptosporidium and some of these CIDTs, false positives. Do you know if anybody is asking the question whether some of this increase couldn't be due to false positives with Cyclospora?
I don't know the answer to that, John.
I don't know the answer either. I've heard similar concerns, and again, I think this is where we need future investments in new laboratory methodologies, in research, in public health. With that, I'm going to really bring this to a close. I see we lost Dawn. I know we didn't get to all of the questions in the chat. We will try and capture them. This recording will be available online, and you should have in the announcement, there were links to our bios. I know we had a lot of also great experts online from the food safety community. And so we hope you found this helpful, and please check out our additional information. We do also have a one-pager on our website around foodborne disease surveillance and kind of a brief that highlights some of the points that we made here today. With that, I would like to thank my panelists, Craig and Sarah, and of course, Don, as well as all of you for taking time out of your busy schedules to come and learn more about this important public health issue. Thank you.